replacement include loosening, as we discussed, stiffness, because you can see you need various degrees of flexion for activities of daily living. Stiffness is a very big problem, and it's very commonly asked by patients, how much flexion will I get after a knee replacement? And literature has shown this time and again, the amount of flexion you have preoperatively, usually that's the amount you'll have postoperatively. Because on table one can get even full flexion, but once the patient wakes up and uses their own quadriceps, they usually go back to from where they started, unless they come to us very early on in their arthritis, which is not usual in this part of the world. And stiffness has to be dealt with by an aggressive rehab program. The patient's pain tolerance has to be improved, and then there are technical factors during surgery that one can do to control that, and that is by using the right size of components, preventing the use of very large components, and to make sure that the joint line is not elevated. These things decrease the rate of stiffness. Similarly, instability is a major issue, and despite knee looking very good on the x-ray, if it's not done meticulously, if the ligament balancing is not good, the patient will be more miserable actually after a knee replacement, because they will have flexion instability going up and down stairs, and this has all improved with the newer surgical techniques. Neurovascular injury, obviously, it's always a risk. The popliteal vessels are right behind, but the literature prevalence is 0.3%, and it's seen in certain patients who have more pre-op valgus deformities. And obviously, wound complications can be done, and these are the routine complications after lower limb surgery. Moving on to total hip replacement, these are the different components. You have a femoral stem, socket, which goes in the acetabulum, the liner goes into this socket, and the head articulates into that ball. So this would be how a post-op knee replacement looks like. Avascular necrosis of the femoral head, we just saw how it looks on the MRI. Immediate post-op hip replacement, and if you can see, after 10 years it looks beautiful, as if it was just done yesterday. No disuse osteopenia over here. Now, the first hip was done in the US in 1969. At that time, concerns were around infection, implant breakage, because the implants at that time were stainless steel. And now we are using cobalt, chrome, and titanium, which have much more fatigue strength. And dislocation was a major problem in those days, because the femoral head sizes were 22 millimeter heads, but now we are using up to 32 millimeter heads. The stem material has changed, as I just discussed, and the stem theories have also changed. We were first using tapered stems, then we went on to cylindrical stems, and then on to anatomic stems. All of these work in different philosophies as to where is the fixation of the stem. Is it in the metaphysis or in the diaphysis? Cement is actually not a glue, it's like a filler between the bone and the implant, and the interface strength of that depends how well the cement is pressurized. Have more flexion at the same time, stable gait while the knee is flexed, so to while doing the joint. And now we are on to a 4th generation cementing techniques. Surface finish of the non cemented implants is another issue, because if you use a very rough surface, that causes abrasion between the implant and the cement, and that causes aseptic loosening. But if you use a polished surface, in that the stem tends to subside. So one needs to find a fine balance between the two, and it's been shown that a surface roughness of 0.4 micrometer gives us the answer. Acetabulum, if it's cemented, gives more problems with revision down the line, and even its long-term results are lesser as compared to cementless acetabulum. And one can use, formerly we used to use these with dome spikes, but now we are using the ones without this, because these tend to cause bone loss when you revise them, and then it becomes a bigger defect. Similarly, we've done away with these dome spikes, and even these increased, if the pore size is too much, if it's more than 400 micrometers, then there is not much good stability. The bone ingrowth is not that good, and that's why. Similarly, micromotion, once these cementless implants are fixed into bone, you can imagine the fine line a surgeon